We are here with Dr. Victor Montori from the Mayo Clinic, and we have a few questions about clinical practice guidelines. So the first question is, what makes grading a guideline useful?
The reason why clinical practice guidelines task forces may want to consider grading their recommendations is to make their guidelines more helpful. And the way grading will make it helpful is if the task forces are able to convey clearly how confident they felt about the evidence, about the research that was supporting their recommendation, about the error associated with the estimates of effect, and separate from that, how confident are they that if patients were to follow the recommendations that the guideline is putting forward, patients and clinicians were to follow their recommendations, that patients will in fact be better off on average. So it is important to keep these two separate because the confidence in the research has to do with the extent to which the estimates are correct, are precise enough, are consistent across studies, and bear directly on the question at hand. And one could have therefore in the grade scheme 4 levels of confidence in those estimates, from the very low quality evidence all the way to the high quality evidence. High quality evidence usually comes from consistent, large, well-conducted, at low risk of bias randomized trials. Low quality evidence usually comes from observational studies that have important limitations. As the observational studies overcome those limitations and find evidence, for instance, of dose response, the quality of evidence for observational studies is rated higher. As randomized trials accumulate flaws and limitations, show inconsistent results, or measure outcomes that don't really matter directly, do not affect directly the question at hand, they also get downgraded appropriately. Thus, there will be 4 levels of quality of evidence, 4 levels to express how confident the task force is about the estimates of effect.